Hello and welcome to Health and Wellness, your guide to the integrated personal and financial retirement journey for physicians. I'm your host, Michael Swartz, Certified Financial Planner and Master Certified Physician Development Coach. Welcome back to the Health and Wellness Podcast. My name is Michael Swartz, Certified Financial Planner and Certified Physician Development Coach. And I'm lucky enough today to have Dr. Jeff Thompson, the Executive Advisor and Chief Executive Officer Emeritus at Gunderson Health Systems here in La Crosse, Wisconsin. Dr. Thompson is a trained pediatric intensivist and neonatologist and served as Gunderson's Chief Executive Officer from 2001 to 2016. In that time, he led several key initiatives, including sustainability, and is generous enough to spend his time today on the podcast. He's also a nationally known speaker and has spoken internationally as the keynote. And with that, I want to say welcome, Dr. Jeff Thompson, to the Health and Wellness Podcast.
Thanks, Michael. Thanks for having me. Boy, with all that introduction, sounds like I'm really old. Oh, I guess I am really old, but I'm always happy to be here. It's lovely to chat with you, and there's important work to be done, so we should get at it.
Absolutely. Thank you for coming on, Jeff. And I would say one thing specifically is age is just a number. And for you, I see you running full speed, even in what we want to call retirement. You just kept it going. And one thing that always impresses me about you is you've always got something going on, including, being generous with your time and on the podcast. And so maybe if we can start there and just talk about your role in leadership at Gunderson. You always had something going on there. You led several initiatives. Could you share a little bit just about your career and trajectory into CEO, and then maybe bring that as a transition into retirement?
Sure. I came to Gunderson to take care of patients and teach. My wife and I thought La Crosse would be a good place to raise our children. We had two at the time. Had one more once we got here. Did not want to go into academic medicine, where at that stage, often every 4 years, 5 years, you had to move to a different place to go from, assistant to associate to from associate to a full professor. I wasn't interested in that. I wanted to have roots. I wanted to settle into a space. We had medical students, we had residents, there was lots of folks to teach. I liked the teaching. You could do research on your own. And I really liked taking care of patients. And so my responsibility, as I saw it, was to work with my wife to have a great place for our children to live, and work with my colleagues at Gunderson to build a great place for children to come be taken care of when they were sick. And so I took care of sick babies and sick children that were in intensive care unit for 35 years. That gave me lots of opportunities to see a lot of parts of the organization, because they would be in the clinic and in the emergency department and the operating rooms and radiology, all the places in between. So I had lots of interaction to connect with the people, lots of opportunities to see how we could do things better. We weren't doing badly, but clearly we could do better, and started by measuring things and being honest. One of the clearest advantages going forward was have the courage to just measure what we're doing and be able to look at it and say, we're not quite as great as the billboard. We're gonna have to actually get these numbers up, because the numbers, they represent real people, and that's the most important part. It's about the real people. It's about children. It's about their families. It's about whole communities. And so I just started doing that. It was easy to find partners. I didn't do any of this by myself. I found fabulous nurses and administrators, other physicians who worked first on making care better for children, then care better in the transitions. And then because I was loud and noisy, or I knew a lot of people, I got elected onto the board. And then after a couple of years there, I got made one of the vice presidents. At those days, the board chose the vice presidents, and that's how I went into more formal leadership. Before that, it was quite informal, managing the unit or doing those things. And I didn't plan that. In fact, I spent my life making fun of people in leadership positions, especially CEOs. I thought they were pretty much just a millstone around the neck of any clinician trying to do something that needed to be done. But eventually, I was the executive vice president of this big organization. Pretty clear in the future, there would be a likely chance that I'd end up being the CEO. So then I became much more intentional about my leadership um, education and approach. I'd done a lot of independent learning throughout my life, and this was no different. So I started reading those journals as well as all my clinical journals. I started going to those meetings as well as my clinical meetings. I started paying attention to the people I thought were the best. And it's one of the great things in medicine that may not transfer in many other fields, is that you have a lot of clinicians that have spent their whole life growing up saying, how do we get better at taking care of patients? There aren't a lot of trade secrets. So if you or your sister is the smartest person in the country on whooping cough, and she's practicing at Columbia, I just call her up. Say, I have this little kid. It's got terrible pulmonary hypertension. I've done this and this and this. I read your paper on that. I've tried that. Do you have any other ideas? And they would always say, yeah, let me look. I'm in the middle of something. Can I call you back in a half an hour? Sure. They don't know me from anybody. They don't even know where Wisconsin is. And so they would call, and then they would say, I don't, but you know what? I have this friend, Elizabeth. She's at University of Minnesota. It's not far from you. She have this abstract that I looked at. It's not published yet. Call her. She will. So I call Elizabeth, and she says, yes, try this. You can, it's not published yet, but we have a number of kids that did much better on this than any of the other things that are published. So try that. So it was a matter of collaborative, broad collaborative speaking, getting things better. So I used that model across the organization, collaborative learning, department to department. We had shared conferences that we did that across our community, La Crosse, and the 19 counties we served at the time, saying, what can we learn? How do we connect? How do we serve the people? The purpose is to serve the people, not to become famous, not to make more money. It's serve the patients in the community. And so this collaborative approach, and then we took it more broadly, of course, around the country, and worked with people all over the place on many different items, the environmental one you mentioned, but on quality improvement, on advanced care planning, on breast cancer care, on all these things, bereavement, so many things. We just said, we will work with whoever's the best. We will be disciplined, have the courage to measure, and disciplined to follow up on those measures, and then stay in it for the long haul, because you don't always make the right decision. And if you don't make the right decision with a sick child or a big organization, it can cause problems for people. So you have to stay with it. You have to keep measuring. You have to say, how can we get better? How can we do that? And because of that, we ended up having success as measured by many outside organizations for serving the community, for improving our quality, for lowering our costs, for helping local businesses. That's the mark of a organization that really lives its values and broadly serves its communities.
Well, I heard a lot in there, and what you're talking about is we don't necessarily need to be the smartest person in the room, but we need to
No,
have the humility to identify that. And specifically, you mentioned working with the best people. And I know you and I have had previous conversations about this, but can you share a little bit more, maybe about how the best person may not be the smartest person? And maybe a little bit from your book, Lead True, talking about how maybe the smartest person is far from the best person, and why those reasons might be.
yeah, well, that's very important to put that out there, Michael, because best, in no stretch of the word, if somebody said, so define best, yeah, I wouldn't start with the smartest. Although we had some very smart people, absolutely brilliant people in many parts, docs, nurses, physical therapists. Some of these people were just amazed, in IT and in administrative activities. We had some very bright people. But the best people for us were the people that were willing to live the values of the organization, that were willing to aim for excellence and not come up with a million mistakes, but go after excellence. They were willing to respect everybody. And they're willing to be able to put themselves second for a greater good, that is the well-being of the patients and the community. And so our best were, you know, giving, thoughtful, hardworking collaborators who even in tough times were able to live the values.
Mm.
And that's not easy, because it's always, I mean, it's, you know, in the book, you mentioned the book, in the book, you know, one of the stories that people bring to me most was a very, you know, very famous neurosurgeon who had great outcomes and was well respected, but treated people badly.
Mm.
And after a complex trying to help him, trying to do a lot of things, he ended up had to leave the organization because he was not smart enough. No, he's brilliant. Not enough skills, great skills, work ethic, tremendous work ethic, but he couldn't treat people well. And if you have someone that treats a nurse badly, really badly at 7:30 in the morning, that increases her chances of making mistakes on patients for another 11 and a half hours.
Mm.
That's not okay. That's not good for her. It's not good for the patients and the family. Who are we serving? Yet not us, right? So our approach was to say, short term, this might be really hard. We're going to lose this person who has all these skills and huge work ethic and all these things. Long term, best for the organization. Do we find a replacement? You bet. Able to treat people with respect? Sure. I mean, none of us are perfect. This wasn't a one hiccup and you're out. We do everything we could to try and keep people in. We had special trainers and we had all this stuff. But we also said, to be fair, you want to apply for a job. Here's our code of conduct. Here's how we all behave. CEO, neurosurgeon, respiratory therapist, doesn't matter. Here's how we behave. And then when you came for your interview, you got it again. And if you came for orientation, you heard it from me in orientation. This is how we're going to treat each other, because I believed no C-suite could figure out all the best solutions. You had to unleash the talents of the staff. And so the way you did that was give them enough structure, where we're going, our mission, our vision, a set of values, and then a set of way to treat each other. If we did that, then you unleash the amazing talents of these nurses and docs and therapists and IT folk. I mean, we did amazing things for a small organization sitting out here on the prairie. It was stunning, and measured by outside people. Now I was a former CEO, so you think, oh, of course he's on the bandwagon drinking the juice, but outside people, I mean, out health grades and Medicare and Medicaid and the whole international community on environmental activity, the international community on advanced care planning, the breast centers of America got together, and our breast center was the first center of excellence because we had such good outcomes, such terrific outcomes. Because I figured it out, I didn't figure out any of it. I just, our approach was to unleash the staff. So you had this brilliant doc, very disciplined, brilliant group of nurses, nurse practitioners, radiation oncology. I mean, these people that just did such good work. So my approach was to not make it about the CEO or the senior people, but make it about serving a greater good and unleashing the talents of the 7,000. You and I have talked about it, but I've tried to teach this at many CEOs, and they'd say, well, I don't have time to talk to the staff and have open conferences and do all those things you did. I said, well, let me see your schedule. And they'd spend all their time talking to the CFO and the head of HR and the head of IT, and nobody that was in the front lines actually doing the work. And I said, well, here's the problem. The problem is you have a C-suite. You're all very smart. You're all very good. But your 7 people in your C-suite could never outperform my 7,000. Yeah. The 7,000 would always outperform. When they're pulling on the oars, they're always going to outperform it. You can't think of all the things. You will get 70% of their potential.
Yes.
We were getting 120% of their potential.
Which is fantastic. And as you're mentioning that and unleashing, what comes to mind is the Pareto principle, but from leadership, it's inverted. So the 80-20 rule, where 20% of the effort creates 80% of the results. But when it comes from an environmental and leadership position, 20% of the framework will lead to 80% of the behavior, but you leave that
Yes.
other 80%, that gray, to be filled in by the individual to
Yes.
provide that care. And what you've talked about is leadership tends to believe that more administration, more red tape will make the lane tighter, thus lead us more directly to the results. And I think in your experience, that may not be the case. So maybe a little bit more on that.
Yeah, I think you're right, and I'm not saying this model works for everything in the world,
Correct.
um, but in something complex like healthcare, where many people from manufacturing have come in and said, "Oh my, this is a mess. It's people you can't control taking care of people who you can't control. You can't control anything here. This is a disaster. I'm going back to finance or manufacturing or some other place." Um, so it is fairly complex, but that's why you need people. Even now with AI models, our best use of AI in taking care of patients is going to be to rapidly sort through the mass of information that we have stored up and give a thoughtful clinician suggestions on how she's going to take care of her patient. Not say do this, but say as the data would say, here's some things to think about, and then the clinician will re-examine that or do that or that, and then the AI can say, and here are the most likely tests that will help you narrow your diagnosis. So our accuracy in diagnosis is going to be better. The accuracy in therapeutics is going to be better, but not from just magic. It's going to be this combination of a thoughtful, caring, thinking person and this AI suggestions and backup that will do better. So it's you have to have the personal activity of thinking and caring, and you can't make a rule for everything. You tell people do the right thing.
Yep.
You know, one of the in the book, one of the famous stories is about a wedding that happened on a Friday afternoon. We didn't have any rules. We never had a wedding, and some vice president just told a very frustrated doctor that whose patient said, you know, I don't care about my therapy. I want to get married today. The doctor says, we're a hospital. We're not a marriage center. And they said, but you asked me what I wanted. That was I wanted. And the doc said, well, we were taught what matters to the patient, not what's the matter with the patient. And so they found a way. They just figured it out. 2.5 hours. We had a wedding certificate from Winona and a dress from Whitehall and cakes from all. I mean, they put on a wedding. Did they ask me? No. They ask any of the senior vice presidents? No. They didn't ask anybody. They just said it's the right thing to do. Were they living on rules and regulations? No. They were living on principles. What are our values? Health and well-being of the patient. This is the mental well-being of the patient. We'll do what's necessary to help them. And they did. And so it's just a tiny example in thousands of interactions of people saying, what matters is delivering the care and the expertise to improve the health and well-being of the patients in the community. And then they would just do that. I mean, it wasn't me. It was an amazing staff.
It sounds like you've kind of unlocked this trinity of success from a leadership perspective, where you say we recognize that the environment plays a role. We recognize that the tools, the AI that you talked about, will enhance
Yep.
the individual, but at the end of the
Yep.
day, there's an environment, the tools, and the individual, and it's all three. And
Yeah.
leadership might focus sometimes a little bit too much on the environment and how can we make it more rigid. Some might say we need to invest in the tools, and some might say it's the individual, and maybe the outcome there is it's the trinity, the trifecta of those three coming together that creates kind of this magic nucleus of high quality empowered healthcare.
Mm-hmm. Oh, absolutely. You got to decide what's a tool. I mean, one of our real breakthroughs was to say finance and facilities and growth were all tools. They were not the goals of the organization. And although it seems to make a lot of sense for a healthcare organization to say that, the vast majority in the country don't say that. That if you ask people what's the main goal of this organization, say, well, I have enough money to get to the end of the month. My manager talks about money 80% of the time. And so it's a very common problem. Mm-hmm. And we just said, these are tools. Now the board would get very nervous when I would start saying that. And they say, oh my goodness, all soft and mushy physician and he doesn't know about business. Well, our finances over those 14 years were the best finances in the 140 years of the organization. Not because we focused on them every minute. It was because we focused on all these things that inspired the staff to do great work. We didn't say we have to save money so we can get a 3.2% margin rather than a 3.1, which people say all the time. We said people in our counties that we serve go to bed every night worrying that they don't have enough money for heat, medicine, and food. And where are they going to spend their money? That's why we have to lower the cost of care. We have to lower the cost, not because I get a bonus. We eliminated executive bonuses as soon as I came in. There are no executive bonuses. But we're going to save money, not so we all get rich, not so we have a margin of 3.1 or 3.2, which nobody cares about outside of the boardroom pretty much. It's because people go bankrupt because of the cost of healthcare. Yeah. They make choices. They make bad choices. Why do we have a maternal mortality rate in this country that's higher than Rwanda's? Mm-hmm. It's because of the way we finance healthcare. Women who need prenatal care don't come in because they can't afford it. And that's why, because our doctors aren't smart. We have smart doctors, OB doctors, very smart, neonatal people around the country, very good. It's because we don't have a financial system to do it. And people are too poor to do it. So we organize it the other way. It's about patients. You take care of the patients, we'll figure out the finances. And, the secret was there's enough waste in healthcare that we were able to do a lot of things that lost money, like advanced care planning, mm-hmm. but still serve the patient well, and ended up with savings and could lower the cost of care to the community.
Well, it's counterintuitive, isn't it? I mean, looking indirectly at the bottom line for better patient care and more efficiencies throughout, yes, that maybe are slightly counterintuitive, but ultimately do lead to that margin of 3.2 versus 3.1, but not directly.
Yeah, and that's for leadership stuff. It's one of the things that people talk about often is that you can't, you address what you focus on, and that's all you can do. And this was more of a long-term rather than short-term play. Oh, in the short term, could I balance the books and make them higher? Oh, sure, I can do a bunch of stupid things if I'm looking long-term. I mean, after the 2008 and 9 economic downturn, all kinds of people across the country firing staff, firing their old staff, firing their new staff, getting rid of behavioral health, getting rid of education programs, all things that made their quarterly or their monthly financial report look better. And so that the C-suite didn't get beat up by the board, except the organization absolutely got pounded down the road. People got nervous. All the studies have been done, Harvard, Wharton, Stanford, they've all shown that if you fire people, the people that are remaining, the vast majority of them don't work any harder. In fact, the ones with options start looking for other places to go to or keep their head down. People that want to innovate don't, because they're afraid they're going to be outside the lines, and then that's going to be a problem. So the whole productivity of the organization sags after that, doesn't increase. And that's even in the medium term, things are not better. And in the long term, oh my goodness, you lose people that have options, and you're left with people that have no options. Great. That's not how you deliver excellence to the community. So I just said we wouldn't do it. And I went to the staff the other way and said, look, I can never promise we'll never have a layoff. That's going to be the last thing I'm going to do. We're going to do everything we can. If you help me, we're going to get through this without laying people off, because I know you have relatives that are laid off and friends and other organizations getting laid off. We're going to do all these other things first, and we're not going to raise prices on the community. We're not going to do that. Who's going to take a beating? The staff? Nope. The mental health patients? Nope. The community? Employers? Nope. Said the leadership can take a beating. That's what leadership's about. We'll take a beating. We'll go to the board. The board beat on us for months and months, saying you have to do this, have to do that. Maybe you can't find a way. Maybe blah, blah, blah. all these things. But then turns out, after a year of that, well, then we're in a little better shape. In the next year, people around the country were barely getting back on their feet. We were tearing it. And in 3 years, in the third year coming out of it, about 2.5 years after the big drop in 8 and 9, our operating margin was so high that we had to say, how do we change that? How do we lower our prices? How do we do things so that we don't take this much money out of the community? We don't need to have that high a margin. We need to lower that. That was a board discussion because we didn't slaughter the people when it would have been easy to do that. We said, what's important? We have always said the staff are important. Well, then act like it.
Yeah.
A big thing that gets lost on leaders at the time of crises.
Well, putting on that long-term vision hat in spite of a short-term crisis. And
exactly.
You've seen that leadership from a leadership position, and we're coming up here on the end of our first podcast conversation, and so I think we'll put a bow on this and say from a leadership position, and what you've done at Gunderson is certainly unique, and you've got a track record of success to prove it. And in our next conversation that'll publish next week, then we can turn that attention specifically to the retirement journey for physicians and how we really make and optimize not just the career, but that transition into retirement too.
Great. That sounds great.
Wonderful.
Thanks for your time, Michael.
Well, thank you, Jeff. Appreciate your contributions.
You bet.
Thank you for listening to this week's episode of the Health and Wellness Podcast. As always, I'm your host, Michael Swartz, Certified Financial Planner and Master Certified Physician Development Coach. If you're looking for additional resources for integrated physician retirement planning, please visit healthandwellness.com. We'll see you in the next episode.